In this year's Myeloma Knowledge Exchange, or MyKE, I was asked to present and discuss cases related to high-risk multiple myeloma, which is MRD positive after treatment in the newly diagnosed myeloma setting, and also another case on standard risk myeloma who achieve MRD negativity, again, in the newly diagnosed setting. This was done in a very interesting interactive platform, interactive in the IT sense. So it's almost like in the days where you have the Choose My Own Adventure storybook, where at different phases you get to choose an option, and the case will take you based on that option. And it happens in stages, right? So it was quite interesting and interactive format. But essentially, this is part of an overall program that actually look at different aspects of myeloma management. And for newly diagnosed myeloma, currently we have two kind of stratum of patients, those who have high risk characteristics at diagnosis, and those who have standard risk characteristics and at diagnosis. And the management of these patients can be very different depending on drug availability and the countries and regions that you are practicing in. And I guess for the session, that was one of the main discussion point is what are the factors you will use, clinical as well as laboratory factors at diagnosis to identify high-risk patients. And once you have identified these high-risk patients, do you treat them differently? And if you do, what are the different treatment that you will offer them compared to a standard risk patient? So we went on to discuss about what are some of the parameters that we currently have that identify high-risk patients, and this include genetic factors like 17p deletion, 414 translocation, 1416 translocation, 1q21 amplification, as well as some blood-based tests like the ISS staging requiring beta-2 microglobulin and albumin level. And also looking at the combinations of these factors that is more important. So someone with ISS stage 3 and the coexistence of one of these high-risk genetics, this will identify the high-risk patients. Whereas if you only have ISS stage 3 or you only have the genetic factors, they may not necessarily be the highest risk. We also discussed that if you look only at genetic factors like 17p13, then perhaps a high cutoff of percentage of cells with this abnormality become important. So for 17p, more than 50%, rather than looking at just a positive value in 5%, it does make a difference. Similarly, for 1q21, if you look at it alone, then those with amplification, which is 4 or more copies, would be the high-risk ones, versus just a single copy gain. So really, we discussed that the characteristics of high-risk disease are different factors that you can incorporate, including some clinical factors like extramedullary disease, circulating tumor cells that is observed in the patient's blood film, right? And so any one of these things could be high risk. Also, the discussion went on to talk about that today's criteria, looking at just a single factor like revised ISS stage 3 or the genetics, is probably suboptimal. And I discussed the fact that it probably is a good time now to re-establish a set of criteria that can be uniformly applied to identify high-risk patients, something that is easy in the clinic that we can use. And we already have the tools, which I already mentioned, right? Clinical criteria, the revised ISS stage 3, the genetics, but adding in some additional criteria of percentage of tumor cells and number of copies and so on, that can potentially be uniformly applied. Right, so the fair bit of discussion goes into the criteria or what identify high-risk patients. Then the next important segment that we discussed was, okay, now that you have these high-risk patients you have identified, what can you do differently for them? So we talk about what is already known and can be applied today, which is to give patients a second transplant, or what we call do a tandem autologous stem cell transplant. This seems to benefit high-risk patients based on randomized study. We also talked about the use of a PI-based maintenance therapy for these patients rather than a IMiD-based maintenance. And we talk about potentially even combining a PI and IMiD in the maintenance of high-risk patients, but the PI should be there as the backbone. Right, we talk about the fact that with all these additional treatment, the second transplant, the PI-based maintenance, our objective really for high-risk patient is to get them to an MRD-negative state, because studies have shown that if you can bring a high-risk patient to MRD-negative remission, it can potentially neutralize their high risk. So this outcome of these patients can be very similar to the outcomes of the standard risk patients that is also MRD negative. Right, so I think that is an important treatment objective for high-risk patient. Then we also discussed a bit further on what are the things that may be coming on in the next 2 to 3 years that may also be very helpful in improving the outcome of high-risk patients. In fact, maybe even overcoming their risk so that their outcomes are similar to standard risk patient. So some of the discussion point around here is the use of a quadruplet induction treatment that will incorporate an anti-CD38 antibody, whether it's daratumumab or isatuximab, but also the fact that the PI, it would probably be better to use a second generation proteasome inhibitor like carfilzomib in the induction treatment. And then the third agent and the fourth agent will be len and dexamethasone, right? So something like that for induction, we already know based on the German high-risk trial, single-arm study is generating high level of response rate, and about 2/3 of those patients evaluable was achieved MRD negative response. So if we think that MRD negative response is a key treatment objective in high-risk patients, then this kind of quadruplet induction will get a high percentage of patients there. So I think as we get more patients recruited onto, say, the German study and other similar studies in Europe and US, and get to see more of that data, then the confidence level will be higher that this strategy would be the way forward. So this is something that we will see in the next 2 to 3 years. And then slightly further on in the horizon, we also talk about the potential of the immunotherapeutic approach like CAR-T and bispecific T-cell engagers, and incorporating them into frontline treatment either as consolidation or to replace transplant for these high-risk patients in an upfront setting. Again, that will be something further on in the horizon that we can incorporate. So that was a lot of the discussion around what to do, how to identify high risk and what to do for high-risk patients. For standard risk patients, really, these are the group that most of the current advancement in myeloma treatment has benefited the most, right? So the current approach with quadruplet that has been approved, like DARA VTD or with VRD, for the transplant eligible patient, and then going on with a single transplant followed by the IMiD maintenance. These are the so-called standard treatment that we have now, is what we'll do for these patients. For the transplant ineligible patients, standard risk, we probably will treat with something like DARA RD based on the MyKE study that's producing a median PFS of more than 5 years, which is a fantastic outcome. So again, the standard risk patient really should be treated with a standard approach that has been approved based on current phase 3 trials. Then the last part of it is that we then have scenarios where the patients, the responders, or rather the participants, can choose if they're MRD positive, right? And really for patients who are NRD positive, then this actually then escalate the risk, right? So if you are a standard risk patient that with treatment is still MRD positive, you are at higher risk than a standard risk patient that achieve MRD negative. If you're a high-risk patient that is MRD still positive, then you're really high risk. You haven't quite overcome your risk yet. And I think that is the recognition now that MRD is an important risk factor post-treatment. But we also then discuss, is there something different that we'll do with these patients who are still MRD positive? And the discussion is around the fact that we don't know actually. Do we intensify patients for these who are MRD positive? Is that we don't know. So currently the trials are ongoing to look at the strategy of what we call MRD based or MRD adapted treatment in terms of dose intensification or change to a more potent treatment to get patients with MRD are ongoing. So we don't know whether they will actually benefit patients or not. Similarly, the flip side of the coin for the standard risk patient who is MRD negative, could we perhaps truncate treatment or stop treatment earlier? Again, we don't have any clear evidence to suggest that for routine clinical practice. And my discussion was around the fact that there again are ongoing trials to explore these concepts. And when those trials become completed, then we will have the answer to that. But I also highlighted that in my clinical practice, if I have a patient that somehow is requesting to stop treatment earlier because either they have some, they are not happy to continue financial toxicity or whatever, then usually I will suggest that they check the MRD level. If they're MRD negative, then yes, maybe we can explore stopping. But if they're still MRD positive, then I'll highlight that to them as maybe a reason to try to continue treatment unless really the toxicity is very bad or there is no way. Because sometimes patients just feel, not quite the same as completely off treatment, but it's not very significant either. And they're just asking after a few years on treatment whether they can stop treatment and have a bit of a drug holiday. So we will use this MRD assessment potentially as an additional data point in that discussion. So I think that's the whole session. The format was interesting, and we are basically discussing around this two area of in a newly diagnosed patient, how to identify the high-risk patients. Will you do anything differently for them? And then what does MRD positive, negative means for the high-risk and standard risk patient? And some we have very clear answers, some are not yet clear. And in the areas where the answers are not clear, I in my discussion, I highlighted these areas that are currently not cleared and the trials that are ongoing, and also put in context of my current clinical practice, how I actually look at these issues.